friends. The topic I'll be discussing now is congenital heart disease. Congenital heart disease can be classified broadly into two. It's either cyanotic congenital heart disease or acyanotic congenital heart disease. Okay, obviously the major differentiating feature is whether there's a right-left shunt or not. If you look at the cyanotic congenital heart disease, the approach that we have is broadly based on the pulmonary blood flow. The conditions where the pulmonary blood flow is decreased include tetralogy of Fallot, Epstein's anomaly, tricuspid atresia. The conditions where the pulmonary blood flow is increased include total anomalous pulmonary venous communication, transposition of great arteries, and truncus arteriosus. Although there are many more conditions, but what are relevant for our exams are these. In general, one should understand that wherever we have pulmonary stenosis in addition to something, so pulmonary stenosis or whatever, it will come with decreased pulmonary blood flow. So there's no point in adding that in the table and memorizing it because it is self-explanatory. Because the very mention of pulmonary atresia or pulmonary stenosis is obvious, it will come with decreased pulmonary blood flow. The conditions which are associated with acyanotic congenital heart disease include the VSD, ventricular septal defect, the ASD, atrial septal defect, the patent ductus arteriosus, obstructive conditions like coarctation of aorta, and hypoplastic left ventricle. So we'll cover these conditions later, but we'll start with first cyanotic congenital heart disease. Before we discuss about the various congenital heart diseases, let's look at some embryological aspects connected about the way how the heart is developed and the interventricular septum is formed. So I just want to focus first of all on the development of the interventricular septum. And this is the embryological aspects of the development of the interventricular septum. So what you see is, just to look from the side, the development of the atrial septum, interatrial septum and the interventricular septum is, this is the atrial septum, the atria, and this is the ventricular part. In the ventricular part, we have the muscular septum, the muscular part of interventricular septum. Then you have the membranous part, right? This is the membranous part connected to the endocardial cushions. You have the endocardial cushions over here, the perimembranous part. But what I want you to focus on mainly is the conotruncal septum. The conotruncal septum is basically comprised of two things. One is the septum spiral and the other is the bulbar septum. Septum spiral and the bulbar septum. This together is called the conotruncal septum. And the important aspect to remember here is that this septum comes from neural crest cells. So it's a neural crest cell derivative. Among the neural crest cell migration disorders, there's another important problem to understand, that the conotruncal septum may not form. So if you look at this image, you'll have a better idea about what's happening here. You can see that this is the atrial side, this is the ventricular part, there's the interventricular septum that is there, then you have the membranous part, then you have the bulbar part of the septum, and then the spiral septum, and together the bulbar and the spiral septum is what we refer to as the conotruncal septum. And this is where the endocardial cushions are, the AV cushions or the endocardial cushions. So we are looking from the side in these two images. Now looking from the anterior aspect, you can see this is the left ventricle, the right ventricle. You have the interventricular septum that is there. Above, what you're getting is the conotruncal septum. This conotruncal septum, particularly important for us, is the septum spiral, which forms a spiraling course and helps separate out the LV blood to go to the aorta and the RV blood to go to the pulmonary artery. It's difficult to explain these using a two-dimensional image. So what I'll do is I'll show you a small clip, and that will give a better idea about how these various septum spiral is developing particularly. So again, I want you to see from the front that this is the interventricular septum, the left ventricle, the right ventricle. Okay, this is the left ventricle, and then you have the right ventricle on the other side. You have the interventricular septum below and the conotruncal septum coming from above. The green part of it is septum spiral, then you have the bulbar septum, together what we refer to as the conotruncal septum. So what I'm showing here is a video clip about the embryological part of how the interventricular septum is developed. At this point, I want mainly so that you can focus on the interventricular septum, especially the septum spiral. It's difficult to explain how the septum spiral, like a spiral staircase, forms in such a way that it's able to separate the RV blood and LV blood into the aorta and pulmonary artery. So what we're seeing here in this image is, okay, this is the truncus arteriosus, which is connected to the ventricles below. So you have both the ventricles below, and this ventricles, you can see part of the interventricular septum is already formed below. This is the truncus arteriosus. This truncus arteriosus is connected to both the aorta and the pulmonary artery. Now what you can see is they're trying to make this truncus arteriosus transparent, and this truncus, which is arising from both the ventricles, I'm just showing the embryological part of the development of septum spiral. You can see the truncus arteriosus made transparent, and above you can make out that this is the aorta and the pulmonary artery, and then you have a bifurcation point between the aorta and the pulmonary artery. What I want you to focus on is the septum spiral, as to how the septum spiral forms in a spiraling nature. You can see this, as I told you, this is the aorta and this is the pulmonary artery. There is a truncus connecting both the ventricles below. And this is the septum spiral. Carefully see how in a spiraling way it is forming from above, and then you can see the spiral course of it. And what you're noticing below is the septum, bulbar septum, fusing with it. So the bulbar septum and the septum spiral separates the blood from the RV and LV into the aorta and pulmonary artery. And you can see from anteriorly, there's the same thing. There's a truncus arteriosus that is there. You have the aorta, you have the pulmonary artery, the truncus is there, and the truncus is connected to the RV and LV. And you can see again the septum spiral as to how it is forming, the spiraling nature of the septum spiral, and the bulbar septum from below where it is joining with the septum spiral. This allows the LV blood to go behind this septum spiral into the aorta, and you can also see the RV blood going from the front into the pulmonary artery. So the red arrow, as you can see, that is the LV blood going from behind into the aorta, and the RV blood from the front entering into the pulmonary artery. So this is a pretty important point to understand then, that when we look at the embryological part, the septum spiral is very, very important, because connected with septum spiral, multiple congenital heart disease can be explained. As we can see over here, again, this is the truncus arteriosus. You have the red arrow where it is going, that's the aorta. You have the blue arrow where it's going, that's the pulmonary artery. You have the RV, the blood across the septum spiral from the front is entering inside the pulmonary, and then from the left ventricle behind it's going into the aorta. So this is because the formation of the septum spiral is this spiraling nature. So what we just saw was the embryology behind how the septum spiral is able to segregate the blood from the right ventricle, left ventricle into the various great vessels. Now, what we just saw, I'm trying to show you the same thing. We have the right and left ventricle connected with the truncus. The truncus is then dividing into the aorta and pulmonary artery. We have the interventricular septum that is there below. And then you have the septum spiral that's able to separate out the LV blood, that's able to go from behind the septum spiral into the aorta, and the RV blood is go from above, it's able to go into the pulmonary artery. And this is because of the job of the septum spiral. So this septum spiral that is there, the septum spiral that is formed, which is basically separating out the RV blood into the pulmonary artery. And you can already see here that if this is the truncus arteriosus, the blood going from above is what is the RV blood into the pulmonary artery, and in the truncus arteriosus, above the septum spiral is the pulmonary flow, below the septum spiral is going to be the aortic flow. So various defects of the conotracheal septum are going to result in various congenital heart diseases. The most important that we are supposed to know is tetralogy of Fallot. So if you look at the tetralogy of Fallot, come back to this pipe that is there, that is the truncus arteriosus. This is the truncus. And if you look at the truncus, we have the septum spiral separating out the blood of aorta and pulmonary artery. Supposing the septum spiral is shifted anteriorly, the more anteriorly it shifts, is going to squeeze the blue arrow zone, that is the blood from RV entering the pulmonary artery is going to become more narrow. And the more anteriorly it is displaced, the more the zone behind the aorta is going to have, and the aorta is going to get exposed to both the ventricles. So what is happening in tetralogy of Fallot is, if you look at the truncus arteriosus, the diameter is still the same, the embryological part of it, the trunk is there. the septum spiral that is there is displaced anteriorly. The more anteriorly it is displaced, the more narrower it will become for the blood to enter the pulmonary artery from the right ventricle. The more anteriorly displaced, the more wider is the area that the aorta is exposed now, and aorta is able to pick up blood not only from left ventricle but is also exposed to the right ventricle. What this results in tetralogy of Fallot, anterior displacement of septum spiral, is that the RV can't empty the blood out in the pulmonary artery. That zone of narrowing below the pulmonary valve is known as infundibular stenosis. Okay, this area above the septum spiral, which is connecting to the pulmonary artery, right ventricle to pulmonary artery, that is referred to as the septum spiral. The area behind aorta, as I told you, is going to have a larger area now, exposed to both RV and LV, and that is called overriding of aorta. So we can see now just simply displacement of septum spiral is going to explain two important things. One is infundibular stenosis, and the other is the overriding of aorta, as aorta is now exposed not only to left ventricle but also to the right ventricle. The other important concept is right ventricle is normally dealing with a low pressure circuit, that is pulmonary artery. But now that right ventricle is getting exposed to aortic pressures, it is going to hypertrophy, and that is right ventricular hypertrophy. Third and fourth final thing that you can see is that when you have the truncus, the septum spiral got displaced anteriorly, resulting in infundibular stenosis. Overriding of aorta occurred behind it because aorta is getting larger area exposure. RV got exposed to aortic pressure, so it undergo hypertrophy. But the important also other thing that you should understand is you have the septum spiral coming from above and you have the bulbar septum coming from below. They can't fuse with each other. This is because septum spiral is displaced anteriorly, creating a gap between the bulbar septum and the septum spiral. This is going to result in a VSD. This VSD is what we call referred to as a non-restrictive VSD. So when we say tetralogy of Fallot, in reality it's not really tetralogy. It's actually a monology, and all the things in tetralogy of Fallot can be explained by one simple embryological concept, that is the septum spiral is displaced anteriorly. So let me repeat this concept once again, that the septum spiral is a spiral membrane that is there over here. What the septum spiral does is it separates the left ventricle blood from below into the aorta and the right ventricular blood from above into the pulmonary artery. This is the job of the septum spiral. Now what's happening here is that if the septum spiral, look at this as the truncus arteriosus, and this is the septum spiral, and if the septum spiral is displaced upward anteriorly, the area for the pulmonary outflow become more narrow, but as it displaces anteriorly, the area for aortic zone become much more wider. Okay, the red zone, that is the red arrow which I'm showing, becomes much more, and the blue arrow which I'm pointing to pulmonary artery become more narrow. So as the septum spiral is displaced anteriorly, the pulmonary outflow is reduced, so you get infundibular stenosis. As this displaces anteriorly, the posterior area become more larger, so you get overriding of aorta. Because aorta RV is getting exposed to aortic pressure, it will undergo hypertrophy, so you get right ventricular hypertrophy. Because the septum spiral and the bulbar septum should fuse, and they are not in proper axis now, septum spiral getting displaced anteriorly cannot attach to bulbar septum, resulting in a large VSD, and that is called a non-restrictive VSD. So the point that I'm trying to stress here is a simple embryological concept explains all the features of tetralogy of Fallot, and that is the anterior displacement of septum spiral explains the tetralogy of Fallot. So what does tetralogy of Fallot include? It includes infundibular stenosis. It includes overriding of aorta, right ventricular hypertrophy, and non-restrictive VSD. I have been able to explain as to the various abnormalities that can occur when there are defects in the conotruncal septum. I explained to you about how tetralogy of Fallot can be explained by the defect in the septum spiral. I explained to you about how truncus arteriosus and transposition of great vessels can occur. So these are all embryological problems. I mean, the defect seems to be in the conotruncal septum. Further, before we start discussing congenital heart diseases, it's important that we understand about the fetal circulation. So if you look at the fetal circulation, there's just a schematic diagram. So we have the right atrium, the left atrium, the right ventricle, and the left ventricle. Just to give you an idea about how the fetal circulation occurs, the oxygenated blood in the fetus comes from umbilical vein. Okay, umbilical vein. So oxygenated blood comes into from the placenta, picking up oxygenated blood via the umbilical vein, and this umbilical vein is connected to the inferior vena cava via the ductus venosus. So this is the ductus venosus, and this is the inferior vena cava. So what you notice then is the inferior vena cava is receiving blood not only from the lower half of the body, but also it is receiving oxygenated blood coming from the umbilical vein. This blood that is coming, because it's now dual circulation, the umbilical blood that is from placenta carrying oxygenated blood, plus this is going to be relatively on a higher pressure side. So because of this, the force with which it enters the right atrium is going to create a jet mechanism, and the blood spurts directly into the left atrium. Okay, it spurts directly into the left atrium. So what you notice then is, to start with the fetal circulation, oxygenated blood enters via the umbilical vein. Umbilical vein is connected to inferior vena cava via the ductus venosus. The inferior vena cava is getting blood, oxygenated blood at a relatively higher pressure. When it opens the right atrium, the force with which it spurts the blood out is going to push it in the left atrium. So this blood that is coming in left atrium is going to be passed on to the left ventricle. Left ventricle is going to pump the blood out via the aorta, and this upper half of the body, blood is basically pumped via the LV force. So as you know, the fetal heart is beating and it is going to pump the blood out into the upper part of the body. Left ventricle is pumping the blood in the upper part of the body. This head and neck area, upper limbs, the relatively deoxy blood is coming back into the right atrium via the superior vena cava. So relatively deoxy blood is already passed through the head and neck zone and the upper limbs and is coming back via the superior vena cava. This blood that is coming via the superior vena cava is able to enter the right ventricle. The right ventricle is pumping the blood out via the pulmonary artery, and when the pulmonary artery blood is coming out, this pulmonary blood, as you can see, both the lungs in the fetal circulation have got high resistance in a collapsed state, and they are not going to pass much blood. Most of the blood is going to pass through into the ductus, and this ductus is going to push the blood down into the descending aorta and the lower limbs. So to summarize once again the flow of how the fetal circulation occurs, you have oxygenated blood coming through the umbilical vein. From this umbilical vein, the blood passes through ductus venosus. From the ductus venosus, it enters the inferior vena cava. Inferior vena cava spurts the blood out because it comes at higher pressure into the left atrium. Left atrial blood, left ventricle pumps out in the aorta. Ascending aorta, the blood goes to the branches in the upper part of the body. Relatively deoxy blood comes back to the superior vena cava, enters the right atrium, passes into the right ventricle. Right ventricle pumps the blood out in the pulmonary circuit, but because the lungs have high resistance in a collapsed state, most of the blood through ductus arteriosus, this is ductus arteriosus, is going to enter the descending aorta and supplies the rest of the body. So what I have drawn, you can see over here. So what you notice here is this is the umbilical vein. An umbilical vein is getting oxygenated blood. This is the umbilical vein coming from the placenta. So you can see the placenta, this umbilical vein coming, and this umbilical vein is going to give some supply to the hepatic vein as well as the through the ductus venosus into the inferior vena cava. And this oxygenated blood is going through in the inferior vena cava, opening the right atrium. From the right atrium, the force with which it comes, it's going to be entering into the left atrium. It's going to spurt in the left atrium. From the left atrium, the blood enters the left ventricle. Left ventricle pumps the blood out into the upper part of the body, and this is the upper part of the body, goes through the head and neck zone, upper limbs. Relatively deoxy blood comes back superior vena cava. It enters the right atrium. From the right atrium, it's able to enter the right ventricle. Right ventricle pumps the blood out to the pulmonary artery, but because the lungs are not passing much blood through it, because it's a high resistance circuit, the blood from the pulmonary trunk enters into the aorta via the ductus arteriosus, and via the ductus arteriosus, the blood that is coming actually goes and supplies the trunk and the lower limbs. With this also, this basically is the fetal circulation. An important point to remember that means is between the two chambers, right and left ventricle, in the fetus, the chamber that is having higher afterload, because of which it is going to hypertrophy more, or rather it's more thicker, is right ventricle. So in the fetus, you will find that the RV is slightly thicker than left ventricle because it's doing much more work and is pushing the blood into a larger area. The reason why I wanted to explain this fetal circulation is because immediately after birth, we're talking about the expansion of the lung, and as we clamp the umbilical cord, the pressure in the IVC is going to decrease because the umbilical vein blood that is coming from placenta decreases. So the pressure in the IVC comes down to some extent, and the pressure with which the blood is coming from IVC into the right atrium comes down. So what we notice then is the right atrial pressure is coming down. Okay, this right atrial pressure is going to come down. Also, the lungs will start opening as the baby starts crying, and as the baby starts crying and the lungs start opening, the venous return from the lungs come back to the left atrium, and as the venous return is coming back to the left atrium, the pressure in the left atrium rises. This high pressure left atrium will start pushing the septum, and this is the reason, this is the mechanism of how the septum closure happens. So interatrial septum closes physiologically immediately after birth. So let me repeat it once again. How does the closure of the septum occur? What happens is that as we clamp the umbilical cord, the pressure in the IVC decreases. The blood that is coming in right atrium, the pressure comes down. Secondly, as the lungs expand, they start passing blood through it. A large amount of blood passing through lungs via the pulmonary vessel veins come back and open in the left atrium. Left atrium fills and the pressure is high. So simple difference in pressure is going to close this flap. The moment the left atrial pressure rises, is going to shut this flap. And as this flap shuts, that's how the interatrial septum physiological closure happens immediately after birth. The anatomical closure, where the fibrosis, the cementing, everything takes more than a month, but physiological closure of the interatrial septum happens immediately. In some people, the complete closure does not happen, and a small gap remains, and this is referred to as foramen ovale. So this patent foramen ovale might be present in roughly about 25% of people. So it's a pretty common defect. Although if there is a question asking you about most common congenital cardiac defect, generally we don't answer patent foramen ovale because we don't consider it like a congenital defect. Okay, so it is no doubt something that is present in a large number of people, about 25% of people. And I've seen people ask me, is bicuspid valve more common or patent foramen ovale more common? And the answer is patent foramen ovale is in 25%, whereas bicuspid aortic valve is only about 2 to 3%. So anyway, this image, the reason why I wanted to show this image is basically to explain about how the atrial septum closure happens. Now, one important aspect we can discuss before we continue, and that is that let's say the lungs start passing blood after birth, but the pulmonary veins are not normal. If the pulmonary veins are not normal, instead of opening the left atrium, the pulmonary veins are coming back and opening the right atrium. This anomalous pulmonary venous drainage. Normally, pulmonary veins from the lung should open in the left atrium. But instead of opening the left atrium, supposing they put the blood back on the right heart, that is what we call anomalous pulmonary venous drainage. Let's say it's a total anomalous pulmonary venous drainage, means all the pulmonary blood comes back to the right heart. If all the pulmonary blood from the lungs after birth comes back into the right heart, then the right atrial pressure are going to be so high that there's no way how this flap will close, and this is going to remain open. So a patent foramen ovale is definitely going to be present, and an interatrial septum opening is surely going to be there in people with anomalous pulmonary venous drainage. So either they're going to have a patent foramen ovale or they're going to have a atrial septal defect. So that's very, very important to understand that an anomalous pulmonary venous drainage, particularly if it's a total anomalous pulmonary venous drainage, has to have an atrial septal opening. Either it's a patent foramen ovale or it's a atrial septal defect. Another aspect about the interatrial septum I want to draw upon is that in a patient with tricuspid atresia, when the tricuspid valve is atretic and the right ventricle is hypoplastic, then whatever blood is coming from SVC, IVC, the pressure is going to be very high. Since the pressure is very high, even though the pulmonary veins are draining in a normal location, there's not anomalous pulmonary venous drainage, but the pressure in the right atrium is so high that it will not allow the septum to close. So you're definitely going to have an interatrial septal opening or a patent foramen ovale or an atrial septal defect in patients who have got tricuspid atresia. So this atrial opening, I have already explained to you, is definitely going to be present in two important conditions. One is in tricuspid atresia, it will definitely be there, and also in patients with anomalous pulmonary venous drainage, the atrial septum will not close. For these reasons, in these two conditions, especially in patients with anomalous pulmonary venous drainage, the A to P2 is going to be widely split. Okay, like an NASD, you get a wide split, A to P2 wide fixed split. Wide fixed splitting can happen here also. We discussed about the embryological background behind how some of these congenital heart disease defects do occur. Now let's focus on each of them. Let's say if you look at the tetralogy of Fallot, I already explained the four components which are resulting due to anterior displacement of septum spiral. These include the infundibular stenosis, which is nothing but a narrowing below the origin of the pulmonary vessel. Infundibular stenosis. You have overriding of aorta. right ventricular hypertrophy, and a non-restrictive VSD. Okay, non-restrictive VSD. One important concept, as you can understand here itself, is that we do realize that in restrictive VSDs, the flow of blood across the VSD is going to be very less, but the pressure gradients between the two chambers will be so high because of the small VSD that the blood will move a lot of turbulence. That's the reason why the murmurs are very loud. This VSD that you get in tetralogy of Fallot will not be generating any murmur because it's large. The movement of blood will not have much turbulence. So most of the mechanisms of murmur generation in tetralogy of Fallot is because of the infundibulous stenosis. The right ventricle has to pass blood through a narrowed zone into a low pressure area like a pulmonary artery. Because of the difference in the pressure, high pressure right ventricle, low pressure in the pulmonary artery, the blood will move a lot of turbulence, and that generates the ejection systolic murmur. So the main murmur we get in tetralogy of Fallot is the ejection systolic murmur across the infundibular stenosis. So the various features that happen in tetralogy of Fallot, you can see in this schematic diagram. Okay, this is a tetralogy of Fallot. What you can see here is the right ventricular outflow tract narrowing. Okay, this is a right ventricular outflow tract narrowing with a decreased pulmonary flow of blood, making the pulmonary vessel to be small. The aorta is now picking up blood from both RV and LV. This is what we refer to as the overriding of the aorta. We have a large VSD. This is what we refer to as a non-restrictive VSD, connecting both RV and LV. And because the RV is getting exposed to the high pressures of the aorta, it is going to have a hypertrophy. So all these four main features are what we see in patients with tetralogy of Fallot. As I was telling you, that the murmur will not occur across a VSD because the blood is not turbulent, the flow is not turbulent. This is because the pressure gradients, first of all, are not that much. Secondly, the VSD is non-restrictive. For these two reasons, you will see that the murmur generation is mainly because of the flow of blood into the pulmonary artery. Some important concepts to understand about tetralogy of Fallot based on which MCQs are asked in our exam. One of the most important concepts to understand is that in patients with tetralogy of Fallot, cardiac failure will not occur. So to give you an idea about what is cardiac failure, forget about tetralogy of Fallot for a minute. If I just tell you left heart failure features, then left heart, if it's not able to clear the blood forward, the backing up of blood results in pulmonary edema. So the major features of left heart failure are because of pulmonary edema, which results in dyspnea, orthopnea, PND, and on auscultation you will see crepitations. And that is all left heart failure features. The most common cause of right heart failure is left heart failure. If the LV doesn't move the blood forward, backing up of blood across the lung puts pressure on the right ventricle. When right heart can't move the blood forward, backing up blood on the right side results in raised JVP, tender hepatomegaly, and pedal edema. So these are features of right heart failure. The point to understand here is in tetralogy of Fallot, cardiac failure cannot occur because, first of all, pulmonary congestion is out of question. This is a condition with pulmonary oligemia. The blood flow in the lung is actually decreased. So there's no question of pulmonary edema and crepitations. You can't get left heart failure features in that sense. Why right heart failure will not occur is because whenever right ventricle contracts, it's got two options. It's got the pulmonary option, it's got aortic option. And I was telling you that the truncus is still the same. The more anteriorly displaced it is, the larger the area exposed to the aorta. So what this results in, that the RV, whenever it squeezes the blood, it squeezes it forward. Either pulmonary will take it or aorta will take it. It will not have residual blood. So the end of systole, if it is not containing residual blood, backing of blood in the right atrium, raised JVP, tender hepatomegaly, pedal edema will not occur. So it is a very important topic on which a lot of questions come in our exam, and they do ask like, can hepatomegaly occur in tetralogy of Fallot? Can raised JVP occur? Can pedal edema occur? And generally, this is the point to understand that cardiac failure features will not occur in tetralogy of Fallot. Okay, this is one of the most repeated questions. Other things that cannot occur is chamber dilatation. You will not see, at least you are not going to see, LA dilatation, left atrial dilatation, because the blood moving across the lung, reaching the left atrium is very less. You don't see any dilatation on the right side because RV is able to clear the blood forward in the aorta. If the pulmonary is not taking it, then the aorta is going to take it. So this is the reason why you don't see chamber dilatation. So one of the things to understand is cardiomegaly does not occur in tetralogy of Fallot. So 2 points I told you where repeat questions come. Cardiac failure will not occur and cardiomegaly will not occur. What you get actually is a boot-shaped heart in tetralogy of Fallot. The third important point to understand on which questions are being asked is okay, in tetralogy of Fallot, you will not see patients coming with newborn cyanosis. Cyanosis typically takes a few months before it starts getting manifest in tetralogy of Fallot children. And there are many reasons why this could be occurring. One is that hemoglobin F to some extent is protective against cyanosis, number one, because of the higher oxygen affinity with hemoglobin F, number one. Number two is the pulmonary, the systemic resistance actually decreases as the child starts doing more exertion, because exertion causes hypoxia and hypoxia causes vasodilatation. So if the systemic circuit has got high pressure, then the RV is got, if the aorta doesn't receive so much blood, then definitely more blood has to go to pulmonary artery. If sufficient blood is passing to pulmonary artery, then we are seeing good oxygenation and cyanosis will be very minimal or hardly apparent. For cyanosis to occur, right to left shunt to occur, right to left shunt should occur, and more of RV blood, instead of going to pulmonary route, it should go to the aortic route. For the blood to enter the aortic route, aortic resistance should drop, and for aortic resistance to drop, then one of the triggers for that is hypoxia, as hypoxia causes vasodilatation. With vasodilatation, more easy fluid, easy movement of blood occurs in aortic zone, and this is the reason why you'll see more cyanosis can occur. So as the baby starts crawling, walking, moving, more exertion it does, the more likely cyanosis is going to occur because of hypoxia. And hypoxia, as I told you, causes drop in pressure in the aorta or drop in resistance in the aorta. So these are some of the important questions that they ask on tetralogy of Fallot. Other questions that they ask on tetralogy of Fallot are mainly on the TET spells. This TET spells is nothing but the cyanotic spell. This is also referred to as a TET spell. For a cyanotic spell to occur, one of the two things should be there. Either the pulmonary should refuse the blood, rather the right ventricular outflow tract should get obstructed, or the pressure in the aorta should drop, the systemic vascular resistance should decrease. Don't forget, as I told you, the RV has got two options. One, it's pushing the blood in the pulmonary or in the aorta, and how much relatively blood enters aorta and how much part of RV blood enters pulmonary circuit depends on how tight is RV and how easy is it to put in the aorta. So you can understand, if the right ventricular outflow tract obstruction occurs, or the aorta becomes much more easier to pass blood because the blood moves in the lower pressure circuit. These two things are going to cause right to left shunting of blood. Okay, right to left shunting of blood. That means more deoxy blood enters the aorta. So what are the two things? Either the RV entry becomes more tight or the aortic route becomes more easy. In these two conditions, you will notice right to left shunt will occur. Now the questions are, how can RVOT obstruction become more? One of the mechanisms is any exertion, any activity by the child is going to trigger catecholamines, and catecholamines are going to cause infundibulار spasm. Now you should understand that this infundibular zone, that is there, the infundibulum below, this is rich with the beta 1 receptors, and this beta 1 receptors in a normal person also they are there in the infundibulum, but they'll not have much impact because normally the infundibulum is pretty large, but here already it is narrow. When catecholamines rise, the infundibulum can go into more tight spasm, and that will reduce the movement of blood from the RV into the pulmonary circuit. So, or the aortic pressure decreases. Now, the question I told you is, how can aortic resistance decrease? And one of the mechanisms of how aortic resistance can decrease is any kind of exertion, because exertion causes hypoxia, and hypoxia is going to cause vasodilatation, and vasodilatation, as you know, is going to result in decreased systemic vascular resistance. So, two major mechanisms play a role in causing more right to left shunt and more cyanosis. Okay, so when you look at right to left shunt, we saw the mechanisms for RVOT obstruction. One important mechanism is infundibular spasm. The reason for infundibular spasm, I was telling you, is catecholamines via beta 1 receptors. Okay, catecholamines via beta 1 receptor. The mechanism I was telling you about, how systemic vascular resistance decreases, is by any kind of exertion, because exertion is going to cause hypoxia, and hypoxia is going to cause vasodilatation. Okay, exertion results in hypoxia, hypoxia results in vasodilatation, and vasodilatation decreases the systemic vascular resistance. These two main mechanisms are responsible for triggering the right to left shunt, and more right to left shunt occurs, the more the PaO2 will drop, the more carbon dioxide will build up in the body because of shunting of blood, and more acidosis is going to occur. And all these are very strong triggers for stimulating the respiratory brainstem center, and stimulation of the respiratory brainstem center is going to activate ventilation, and this ventilation that is generated because of the stimulation of respiratory center actually is going to result in a hyperventilation, which is what we refer to as kind of a wasted hyperventilation, because unless blood is passing through the lung, whatever diaphragm is contracting, whatever chest muscles are contracting, the air coming in and going out of the lung, it will be futile because it's not able to pass through in the blood because the blood flow is decreased. Okay, so if ventilation is occurring more, also supported by higher perfusion in the lung, definitely more oxygenation would have occurred. But now we are saying that we are seeing a mismatch where ventilation is there but the perfusion is not there. So I told you already, right to left shunt is occurring, blood is bypassing the lung and entering the aorta, less blood, but this is going to stimulate the brainstem. It's going to activate respiratory centers, triggering hyperventilation. This hyperventilation in a child is going to consume more oxygen because the diaphragm is going to eat up some oxygen, the chest muscles will consume oxygen, and all this oxygen that is getting consumed will further going to precipitate hypoxia in the body. More hypoxia is going to further decrease systemic vascular resistance. So this kind of a circuit that occurred where we are noticing that the child is going to start developing cyanosis, and ideally what should have happened is the cyanosis should have become more deeper and deeper until the outcome should have been a seizure or a collapse, a syncope, something would have, those kind of things is what we would have anticipated. But generally that doesn't occur because the children know how to break it, or the mother knows how when the baby is becoming blue what to do. And one of the things that they do is the increase in systemic vascular resistance. How they increase systemic vascular resistance is, if it's an older child, then squatting is going to be the mechanism, or if the baby is small, then the mother will do the knee elbow position, or the knee elbow flexion. So flexing of the legs at the groin, putting the knees on the abdomen, what we commonly refer to as the knee elbow flexion position, is going to result in increased resistance in the, because the femoral vessels, when they get folded, the pressure in the aorta is going to increase. So as the legs at the groin level are folded and the knees are brought near the chest, then what we notice is more resistance in the aorta. The higher the resistance in the aorta, the circuit is broken, and because the circuit is broken, the cyanosis stops. So generally the way how they abort the TET spell or to stop the TET spell is either by going into squatting or into this knee chest position, and this is going to reduce the resistance, or rather increase the resistance in aorta. And the higher the pressure in the aorta, lesser blood it'll take. And I told you RV is going to squeeze the blood forward. If aorta is not taking the blood, then definitely more blood enters the lung. Better lung perfusion of the lung is going to increase oxygenation of the body. So these are very simple concepts behind how a cyanotic spell occurs. The question is, how do we treat these patients? We block in a very systematic way each of these points. We block the beta 1 receptors, the actions of catecholamines, by using beta blocker. We block the wasted hyperventilation triggered by the stimulation of the respiratory centers in medulla by using morphine. Definitely we give oxygen to the child, humidified oxygen. You do realize that oxygen alone would not have worked. Oxygen alone would not have worked in these children because this is a shunt scenario, but we are reducing the shunt by increasing the pressure in the aorta, allowing better perfusion of the lung. Definitely now oxygen is going to might benefit. So to summarize once again about how the cyanotic spell is precipitated, I told you there are two main mechanisms. Either the pulmonary blood flow should become more difficult, rather RV, outflow tract obstruction, should occur, or the pressure in the aorta should decrease, and that is systemic vascular resistance should decrease. Simple concept I was telling you about how the RVOT obstruction is going to occur. One of the mechanisms is infundibular spasm. Infundibular spasm is triggered by catecholamines. Via the beta 1 receptors, they are going to precipitate RVOT obstruction. I was telling you about how systemic vascular resistance decrease. One of the mechanisms of how decreased resistance in the aorta can occur is any kind of exertion might trigger hypoxia. Hypoxia can cause vasodilation, and vasodilation decreases resistance in the aorta. If these two things are occurring, there will be more right to left shunt. If there is right to left shunt, then the baby is going to be more cyanotic, and this is going to develop what we refer to as a TET spell or a cyanotic spell. During the right to left shunting of blood, you can obviously understand that blood is bypassing the lung, so oxygenation in the body will decrease, carbon dioxide will build up, acidosis is going to occur. And all these are important triggers for the respiratory feedback center to trigger hyperventilation. But the hyperventilation is not going to help much because there is no blood flow in the lung is not increasing, only ventilation is, and that ventilation is kind of a wasted hyperventilation, and rather the diaphragm is going to consume more oxygen, the chest muscle is going to eat up more oxygen, triggering more hypoxia, and that hypoxia is going to precipitate a further decrease in systemic vascular resistance. And all these things in a circuit then are going to precipitate the cyanotic spell. The way how to abort the cyanotic spell, which they themselves might be doing, the patients or the relatives themselves, is that you'll notice that the child, if slightly older, will go into squatting position. Resistance, as the femoral vessels fold in the groin, the resistance in the aortic circuit will increase, making it more difficult for the RV to put blood in the aorta. This means more blood has to enter the pulmonary artery. As the right to left shunt decreases because of this, more blood enters the lung, allowing better oxygenation, so cyanotic spell will abort. Another way how this is aborted is the mother is able to fold the legs at the groin, and making the knees come near the chest. Folding the legs is also going to be increasing resistance in the aorta. So these are the two techniques. Obviously, when the patient is coming to us for treatment, then the ways how we break this is we put the child on beta blockers. If the cyanosis is there, then we give oxygen, we give morphine to suppress the wasted hyperventilation, we give alpha agonists like phenylephrine, and all these are going to help us in breaking the right to left shunt and reducing the cyanotic episode. So this is in brief about some of the questions that they ask in our exam about tetralogy of Fallot. The other thing that one should be aware of is the procedures that are done in the treatment. We do palliative methods to allow better perfusion of the lung, and we also go for corrective surgery. So palliative methods that we do for tetralogy of Fallot, we have the Blalock Taussig shunt, the Blalock Taussig Thomas shunt. So this BT shunt, as it's popularly known as, is two types. We have the conventional one, then we have the modified BT shunt, where we use a graft, which is site-to-site anastomosis between the pulmonary artery and the subclavian artery. So we connect up the pulmonary artery to subclavian artery. What this allows is the high-pressured subclavian is going to put blood in the pulmonary circuit, allowing better oxygenation. So this reduces the cyanotic episodes. So one is Blalock Taussig shunt. Then we have the pot shunt. In the pot shunt, we have the descending aorta anastomosed with the, so a shunt is created between the descending aorta and the left pulmonary artery. Okay, the left pulmonary artery. We also have something called the Watterson shunt. This Watterson shunt is ascending aorta is connected to the right pulmonary artery. Okay, ascending aorta is connected to the right pulmonary artery. So these three palliative shunts are potential MCQs. One should be clearly aware of them. The BT shunt, pulmonary artery subclavian connection. Pot shunt is the descending aorta and the left pulmonary artery connection. Watterson shunt is the ascending aorta and the right pulmonary artery connected. Obviously, apart from that, we do go for a corrective surgery. So these are all the important things that one should be aware of in tetralogy of Fallot. Finally, what's remaining is the chest X-ray. The chest X-ray is going to show pulmonary oligemia. This is decreased perfusion of the lungs. So you will see hardly any vascular markings. So you'll see pulmonary oligemia, and also what we see is a boot-shaped heart. Okay, this boot-shaped heart is also referred to as a core and sabot. Core and sabot. So you can see here, this is the boot-shaped heart. You can clearly make out that the pulmonary vascular markings are hardly there, so there's a pulmonary oligemia. You can make out the shape of the heart kind of looks like a boot. Okay, there's a boot-shaped, so it's a boot-shaped heart, also referred to as a core and sabot.